let's get started. So, on Friday we were going over some of the factors that affected cardiac output, okay? And remember, this is an important relationship right here. Cardiac output, it's not really equal, but it's proportional to the heart rate times the stroke volume, okay? And well, actually it is. So there's two factors that can affect cardiac output. There's heart rate and there's also stroke volume. As I said, Friday we went over some of the factors that affected the heart rate, which is, can anyone name one of those factors that affects heart rate?
Pain.
What's that?
Pain.
Pain?
Yeah.
Yeah, actually it can. Because there are inputs to the cardiac center, the medulla oblongata, from higher brain centers. Okay, it's not really a typical one though, and that's that might even be mediated through the autonomic nervous system, through the sympathetic division, which is what that is actually that's one of the factors that can affect heart rate is autonomic stimulation of the heart, either by the sympathetic division, which speeds it up, or the parasympathetic division, which slows it down. Okay. What's another factor? There's a reflex we talked about last week that affects the heart rate and therefore the cardiac output. I'll give you a hint. It's a reflex that involves the heart. What was the name of that? Anybody remember? Okay, it's a baroreceptor reflex. Okay, baroreceptors are stretch receptors that are located in some of the arteries above the heart. When blood pressure increases, those baroreceptors are stimulated. They increase their rate of firing of action potentials. Those signals are sent to the cardiac center through the glossopharyngeal and the vagus nerve, and that will slow the heart down. Okay, so blood pressure drops, just the opposite occurs. Then the baroreceptors decrease their rate of firing. That signals the cardiac center that that the heart rate needs to be increased in order to increase cardiac output. Okay, so autonomic stimulation. Another factor was the baroreceptor reflex. Also the chemoreceptors, which are involved in regulation of respiration. They also have inputs to the cardiac center, so increases in CO2, which stimulates respiration, also will cause an increase in the heart rate. Okay. And then another one were chemicals like epinephrine and caffeine, and a lot of other stimulants, and then also exercise. Exercise will increase the heart rate by way of stimulation of proprioceptors, which are receptors in joints and tendons and muscles that send a signal to the brain, letting the cardiac center know that you're undergoing physical activity, because those proprioceptors are being stimulated. Okay, so those are some of the factors that can affect heart rate, but cardiac output can also be increased by increasing stroke volume. Stroke volume is the volume of blood that's pumped by the heart with each cardiac cycle. Okay, more specifically with each systole, okay, which is the stage of ventricular contraction. So there's three factors that can affect stroke volume. The first is called preload. Okay, that's something that happens before systole. Okay, and then the second is contractility, which we've talked about before. That's just simply the strength of contraction. And then another factor, which we haven't talked about before, is afterload. Okay, so let's start first with preload. Preload is the amount of tension in the walls of the ventricles immediately prior to contraction. And that tension is produced primarily by the volume of blood that fills the ventricles. Okay? The more blood that fills the ventricles, the more the ventricles stretch, and the more tension is produced in the walls of the ventricle. Walls of the ventricle are sort of like the walls of a balloon. They have elastic fibers, and when it stretches, it recoils. So as a consequence, the more blood that fills the ventricles during diastole, the stronger the heart will contract, and the more blood that the heart will pump. And that amount of blood is what we call the stroke volume. Okay? So there's a relationship then between the end diastolic volume and the amount of stretch in the ventricles, which translates into a larger stroke volume because the ventricles contract more strongly. We'll explain why that occurs here in just a little bit. Okay, so stroke volume is proportional to the end diastolic volume. In other words, this is explained by two physiologists with the last names of Frank and Starling. And this relationship is called the Frank-Starling law of the heart, or simply just Starling's law of the heart. And one way of wording that is that the heart will pump whatever blood it receives. Because the more blood it receives, the stronger it contracts and the more blood it pumps. Okay? So you could this is how you explain the Starling's law in simple terms. A more complex explanation is this one here. The greater the end diastolic volume, the more ventricles stretch, and the harder they'll contract. Okay? Now, the explanation that physiologists have come up with for this phenomenon, which is known as Starling's law, has changed. Originally, they thought that the reason that the heart contracts more strongly, the more it fills with blood, is because when the heart filled with blood, it would stretch the sarcomeres to a more optimal length. And so if the sarcomeres have a more optimal length, more cross bridges could form between the thick and thin filaments. That's how they used to explain it, but that idea has now been rejected. Instead, it's now thought that the more the heart is stretched, the more permeable the sarcolemma becomes to calcium. Okay, so what may actually be happening is when the ventricles stretch, it stretches out the membrane of the cardiac muscle fibers, and when you stretch that may actually force open the calcium channels. That allows more calcium to enter the cardiac fibers. And the more calcium you have in the cytoplasm during the depolarization phase of the cardiac muscle fiber, the stronger the contraction. Okay? Because calcium binds to troponin. Troponin moves to the side, uncovering the binding sites on the thin filaments for the myosin heads. Okay, just like in skeletal muscle. The more calcium you have, the more cross bridges that can form, and the stronger the contraction. So Starling's law is now being explained in terms of calcium. The more calcium you have, the stronger the contraction. Okay. Now, another way of increasing stroke volume is to increase contractility. And contractility can be increased by applying a number of different chemicals to the heart. These chemicals that increase contractility are called inotropic agents. And one of the inotropic agents, which is naturally produced by our body, is norepinephrine. That's released by the sympathetic postganglionic fibers. Norepinephrine binds to the beta receptors on the heart, and that increases not only the contractility, which increases the stroke volume, but also the heart rate. Another chemical that can bind to those beta receptors on the heart is epinephrine. Epinephrine is secreted by the adrenal medulla. And remember, the adrenal medulla is thought to be modified sympathetic postganglionic fibers, which ordinarily secretes norepinephrine, a similar compound, but fibers in the adrenal medulla release epinephrine into the bloodstream, and that circulates through the whole body, and some of that gets to the heart. When it gets to the heart, it stimulates those beta receptors, just like norepinephrine. Epinephrine, by the way, also goes by another common name of adrenaline. That's when when you hear about someone having an adrenaline rush, that we're talking about epinephrine. Okay. Another factor that can increase contractility is hypercalcemia. If you increase the concentration of calcium in body fluids, that's going to increase contractility, because if you increase the concentration of calcium in the extracellular fluid, that's going to increase the concentration gradient for calcium. So when those calcium channels open on the surface of the cardiac muscle fibers, or the contractile fibers, you're going to get more calcium diffusing into the contractile fibers. And the more calcium that diffuses in, the more cross bridges can be formed. And the more the more cross bridges that are formed, the stronger the contraction. Okay? Then there are some drugs that can increase contractility. One drug that was used in the past that's really no longer used because the physiological dose is very, very narrow, and if you give just a little bit too much, it can be fatal. So it can have some bad side effects. There's a drug called Digitalis, and what Digitalis does is it inhibits the activity of the sodium-potassium pumps in the sarcolemma of cardiac muscle fibers. And by decreasing the activity of the sodium-potassium pumps, that actually causes the heart to beat more strongly. So Digitalis at one time was used to treat congestive heart failure. Congested heart failure is when the heart no longer pumps all the blood it receives, and so blood starts accumulating in the ventricles, causing the ventricles to stretch. And if they get stretched too far, the ventricles can actually get weaker. So Digitalis was used to increase the strength of contractions. Okay? But there are better drugs that do that now. Problem with Digitalis, if you got just a little bit too much, it could kill the patient. So there's safer drugs to use now. And actually Digitalis Digitalis is sort of a favorite drug of mine. Not that I use it, but it's just because it reminds me of the plant that it was first found in. Digitalis comes from a plant called purple foxglove. It's got a really pretty purple flowers. And one of the favorites of mine is because there's a lot of it growing near where I grew up in Oregon. In fact, there was a lot of foxglove that was in just growing wild around the yard of where my parents live in Western Oregon. Purple foxglove contains some cardiac glycosides, which include Digitalis and related compounds. And so you want to be careful with this plant around children, because if they eat it, it can kill them because of that drug, because of Digitalis. This is a picture of some. This is a domesticated variety The ones that grow in the wild aren't quite as showy. They don't have quite as many of those flowers in the stalks. But it is a very pretty. I read earlier today that during World War II, purple foxglove was planted in the United States because they had a hard time getting it from overseas because of some of the blockades. So they grew it here and then they extracted it to obtain digitalis. And then another drug that can increase strength of contraction is glucagon. Glucagon is actually a hormone released by the pancreas that increases blood sugar levels, but it also increases contractility. And then other drugs like caffeine. Caffeine, there's probably a few others. Some of them are probably illegal drugs like methamphetamine. Caffeine also. Caffeine probably works though not by acting directly on the heart. It's actually a central nervous system stimulant. So it stimulates the brain, and that causes the brain to increase its sympathetic stimulation of the heart. So these are just a few of the many chemicals that can increase the stroke volume. Now, a third factor that affects stroke volume is called the afterload. And the afterload is mainly just the resistance to the pumping of blood by the heart. And one of the most significant contributors to afterload is hypertension or high blood pressure. Hypertension is when the pressure of the blood in the arteries excuse me, is higher than normal. And if the pressure in the arteries is higher than normal, it's going to make it harder for the heart to push the blood out into the blood vessels. So that's called an afterload. And so that increase in blood pressure increases afterload, and that will actually decrease stroke volume. So more blood will stay in the ventricles if there's high pressure in the arteries. Another malformation that can increase afterload would be aortic stenosis. That's when the diameter of the aorta is narrowed. Sometimes that can be a congenital defect. That can increase resistance to the pumping of the heart, and that also can reduce stroke volume. Of course, your body can always compensate that, though, by increasing heart rate, but that would cause a person's heart rate to be higher. Okay. Now, another factor that can increase cardiac output in general by stimulating an increase in both heart rate and stroke volume is exercise. Okay. Actually, even before you begin doing exercise, just the anticipation of an activity can cause an increase in sympathetic stimulation of the heart, which will increase both heart rate and contractility. So that affects both heart rate and stroke volume, which increases cardiac output. But once you get going, once you get started, when you start moving, that movement is going to stimulate those proprioceptors. Proprioceptors, remember, are concerned mainly with just monitoring the position of body parts and the movement of body parts. So your brain knows where your limbs are located during an activity. But those signals from the proprioceptors also travel to the cardiac center. And that's a signal that tells the cardiac center that you're moving. And if you're moving, you're going to probably need more oxygen. And so that stimulates an increase in sympathetic stimulation of the heart and blood vessels, both of which will increase cardiac output. And then, as exercise continues, muscular activity increases venous return, which increases the preload via Starling's law, and that will increase cardiac output. Now, the reason that muscular activity increases the venous return, and we'll probably take a look at this on Wednesday when we start talking about regulation of blood pressure, is most of your veins in your limbs, like your legs, are located between large muscle masses. And so when your muscles in your legs contract, it actually squeezes the blood in the veins, and that pushes the blood upward through the veins up towards your heart, and that increases venous return to the heart. And actually, breathing also increases venous return, because usually when you're exercising strenuously, you're breathing harder. That breathing actually will help to draw blood back up to the heart. And the more blood that fills the heart, then the stronger the contractions and the greater the stroke volume. Another factor that can increase stroke volume and therefore cardiac output is training, especially aerobic training. Training can lead to hypertrophy of the ventricles, which makes them stronger, which increases the stroke volume. And that's why really well-trained athletes, like cyclists that do the Tour de France, and athletes that run marathons, they sometimes have heart rates below 50, sometimes in the 40s. I've even heard of some that had a resting heart rate below 40, which generally alarms medical practitioners unless they know that they're an endurance athlete. And the reason their heart rate is so low is that the training has increased the thickness of the walls of the ventricles, so the ventricles can pump more blood per contraction. So the heart doesn't need to pump as fast in order to maintain a needed cardiac output. So Lance Armstrong, which any of you heard of him?
Yeah.
Okay, he was in the news a long time ago, possibly before some of you were even born. He actually was a 7-time winner of the Tour de France. Tour de France is what is it? It's like a 10-day long bicycle race through the Alps of Swiss Alps in Europe, and the French Alps in Europe. He was a 7-time winner, and he had a resting heart rate of only 32 to 34 beats per minute. Unfortunately, he got caught cheating. he got caught using EPO, which stands for erythropoietin, which boosts red blood cell production, which increases your aerobic capacity. And so he got banned from the sport. He could no longer compete in cycling events. After he got banned, though, he picked up some other sports that weren't regulated as tightly by cycling. He started doing things like ultra marathons, which a lot of them are just very casual events and don't have a lot of rigid rules or drug testing. So there's usually not a lot of money involved either. So they don't really care. It doesn't really matter who wins, because you don't win anything other than just pat on the back sometimes. So in summary, you need to remember, this is important, cardiac output is equal to the heart rate times stroke volume. Heart rate is controlled by the autonomic nervous system, supplemented by a number of sensory inputs, like inputs from the baroreceptor reflex and from chemoreceptors, and also it's influenced by chemicals. Stroke volume is proportional to the end diastolic volume according to Starling's law. Stroke volume can also be affected by chemicals, including norepinephrine and epinephrine, and afterload. And cardiac output is increased in exercise via several different mechanisms. Another mechanism I didn't even mention that plays a role in increase in cardiac output during exercise is when you exercise strenuously, usually you build up more CO2 in your blood. The CO2 is a byproduct of aerobic respiration. And CO2 stimulates the chemoreceptors. Chemoreceptors in turn have inputs to the cardiac center, which increases sympathetic stimulation, which increases heart rate and stroke volume. So that's another mechanism by which exercise increases cardiac output. Okay, that's the end of this section, so we're going to go ahead and go on to the next section. The next section is concerned with blood vessels and circulation. Now, we could probably go directly into blood pressure because cardiac output is one of the two factors affecting blood pressure. But blood pressure is affected by the structure of blood vessels. So in one way, it makes more sense to talk about the structure of blood vessels before we get into blood pressure, which is what we're going to do. So, first thing I think it's important to know is that arteries always carry blood away from the heart. Doesn't matter if it's in the systemic circulation or the pulmonary circulation. If a blood vessel is carrying blood away from the heart, it's always an artery. Now, some people might define an artery as blood vessels that carry oxygenated blood. That's not always the case, though, because the pulmonary arteries in the pulmonary circulation carry unoxygenated blood. So you can't say that arteries always carry oxygenated blood. It's not the case in the pulmonary circulation. But they do always carry blood away from the heart. And so then veins, which return blood back to the heart, they always carry blood towards the heart as opposed to away. And then in between the arteries and veins, we have the smallest blood vessels, which are called capillaries. Capillaries are sometimes called the functional units of the cardiovascular system because that's where gas exchange occurs. That's where oxygen is delivered to tissues and carbon dioxide is picked up by the blood. Okay, so that's why it's called the functional units. Actually, everything in the body has a function, but that's capillaries and ones. Arteries and veins are mostly just the routes through which blood flows. Capillaries, though, is where the blood actually functions. Okay, both the capillaries in the organs of the body as well as in the lungs. Now, no matter whether you're talking about an artery or a vein, both arteries and veins have three layers. The deepest layer, which is the layer that's in contact with the blood that's in the lumen, which is the hollow portion of the blood vessel, is called the tunica interna, or it's sometimes called the tunica intima because it's in intimate contact with the blood. This is the one that lines the inside of the blood vessel. The tunica interna is made up of an endothelium. Endothelium is a layer of simple squamous epithelium that overlies a basement membrane. And there's also a sparse layer of loose connective tissue that overlies the basement membrane. So the tunica interna is mainly just an endothelium. It's just mainly just a single layer of squamous cells. Then the middle layer, which is sometimes the thickest, is the tunica media. Media means middle, or the median. Tunica media consists of smooth muscle, collagen, and sometimes elastic tissue. But the relative amounts of the smooth muscle and the elastic tissue vary considerably. Okay, and you'll see, you'll have an idea of the relative amounts when we go through the different types of arteries and veins. Then the outermost layer, which is a fairly thin layer, is called the tunica externa or tunica adventitia. That consists of loose connective tissue that often merges with that from other blood vessels. Sometimes it holds blood vessels together, like it'll hold an artery and a vein together in an area of the body. So up here in this corner, this kind of shows the different layers. This real thin, dark layer is the tunica interna. This thicker, lighter purple layer and dark purple layer, both, is part of the tunica media. And then this outer layer is the tunica externa. Okay. All right, so let's take a look next at arteries. Now remember, both arteries and veins have those same three layers, but the composition of some of those layers is different. So the very largest of the arteries are called conducting or elastic arteries, or just large arteries. These are arteries like the aorta and the pulmonary trunk, as well as the pulmonary arteries. They have a layer of elastic tissue called the internal elastic lamina between the tunica interna and the tunica media. So this is the layer right here of elastic tissue. Okay, it's a fairly thick layer, and that allows the elastic arteries to stretch, which is important because when the heart pumps blood out of the heart and into the aorta and the pulmonary trunk, it's under a lot of pressure. It's under high pressure. That high pressure causes the walls of those large blood vessels to stretch. When those walls stretch, that relieves some of the pressure. And so the ability of those large vessels to stretch is important because it evens out the blood pressure. If those large vessels, like the aorta, had solid walls that couldn't stretch, then you'd see a lot higher spikes in blood pressure. During systole, blood pressure would become very high, and then it would drop down during diastole. And the problem with having really high blood pressure spikes is that can increase your chances of getting an aneurysm, which is when the walls of a blood vessel balloon out. They get weak and they start ballooning out like a balloon. And if one of those aneurysms rupture, you can bleed to death internally. Okay. So conducting arteries expand during systole, recoil during diastole, therefore evening out the blood pressure, so you don't have such large spikes in blood pressure. Then the next smallest arteries are the distributing or muscular or medium arteries. These make up most of the named arteries in the body, besides the largest arteries. So these make up all those little arteries that you learned in lab a couple weeks ago. So it makes up like the renal arteries and the adrenal artery and the celiac trunk, superior mesenteric arteries, iliac arteries. Those are all medium arteries. They have up to 40 layers of smooth muscle in their walls. which makes up about 3/4 of the thickness of the blood vessel. And that smooth muscle is under control of the sympathetic division of the autonomic nervous system. And so the sympathetic division can control the diameter of those blood vessels, thereby changing the peripheral resistance. And by changing the peripheral resistance, that can affect blood pressure. If the diameter of the blood vessels decrease, that increases peripheral resistance, that squeezes down on the blood harder, that increases the blood pressure. That's another way that blood pressure can be regulated. Then the next smallest arteries are the resistance or small arteries. These have up to 25 layers of smooth muscle. These are so small that most of them are not named. And the very smallest of the resistance arteries are called arterioles. Arterioles eventually supply the capillaries, which are the very smallest blood vessels. Now, there's also a type of arteriole called a metarteriole. And metarterioles can bypass capillary beds. So a metarteriole is a type of anastomosis. Can allow blood to bypass going through the capillaries. Instead, blood can just go directly from one arteriole to a venule, which is a small vein. So this happens like in your skin when your skin is exposed to cold. There's small, smooth muscle fibers that surround the capillaries that are supplied by the metarteriole. And when your skin is exposed to cold, those smooth muscle fibers contract, and that causes the blood to bypass those capillaries, and thereby decreasing heat loss from your blood. If you get too warm, then those smooth muscle fibers surrounding the capillaries relax. That allows the blood flow to go through the capillaries. Some of those capillaries are very near the surface, and so that allows the heat from the blood to dissipate into the environment. Now, besides being called the functional units of the cardiovascular system, capillaries are also sometimes called the exchange vessels because it's in the capillaries where respiratory gases are exchanged. And also, it's where waste products are picked up by the blood, is through the capillaries, along with hormones, and it's also where cells like neutrophils enter and leave the bloodstream to get into infected tissues. So capillaries have very, very thin walls. They're composed of an endothelium, which is just a single layer of squamous epithelial cells surrounded by a basement membrane, and then sometimes a very, very thin layer of loose connective tissue. So the diameter of most capillaries is actually smaller than the diameter of a red blood cell, which is kind of surprising because red blood cells have to pass through capillaries. So in order to do so, the red blood cells actually have to be squeezed down so they can get through the capillaries. Now, as it turns out, there are 3 different kinds of capillaries. Just as we saw, there were 3 different kinds of arteries. Most of the capillaries in our body are called continuous capillaries. Continuous capillaries, the walls are continuous. And they're continuous because the endothelial cells, like right here, are held together by tight junctions, which are protein complexes that hold the cells very tightly together. So these types of capillaries do allow for exchange of solutes and gases because the walls are so thin. but they don't allow larger molecules or blood cells to pass very easily through their walls. And continuous capillaries have cells like this one right up here, this pink cell. It's called a pericyte, P-E-R-C-Y-T-E-S. Those have some of the same contractile proteins as muscles. So they have actin and myosin. And those pericytes are kind of like a smooth muscle fiber. They can contract and thereby controlling the flow of blood through the capillaries. They can actually cut off the flow of blood through a capillary. So they regulate blood flow. This large pink thing in the middle, that's a red blood cell. That's an erythrocyte. So notice how it's not perfectly round in outline. That's because they have to squeeze, they have to be squeezed through the capillaries because the capillaries have such a small diameter. And the second type of capillary is called a fenestrated capillary. The word fenestration literally means window, but in this case it actually refers to small holes in the walls of the endothelial cells. So if you look really closely, you can see there's actually little pores in the walls of the squamous cells. And those pores allow for the capillaries to be more permeable. So fenestrated capillaries are found mainly in the kidneys, where filtration occurs in the kidneys, and also in the small intestines where nutrients are absorbed. By having these pores, that allows nutrients like glucose and amino acids and mostly glucose and amino acids to be absorbed into the bloodstream. In the kidneys, these fenestrated capillaries are found in the renal corpuscles, which is the first part of the nephrons where filtration occurs. So, this word fenestrated always reminds me of another term, defenestrated. Defenestrated is what happened to some individuals during World War II. Defenestrated means to be thrown out of a window. Sometimes that's the way they executed people, was by pushing them out a window and like on a multiple story building. Then finally, a third type is a very different looking type of capillary. Third type, but they're considered to be capillaries, are sinusoids or discontinuous capillaries. Sinusoids are just irregular shaped blood-filled spaces with large fenestrations. And sinusoids are found mainly in the liver and also in red bone marrow. The sinusoids in the red bone marrow is where new blood cells are produced. And so in the liver there's sheets of cells. They're called hepatic. Hepatic sheets, and in between those are blood-filled spaces. The blood-filled spaces are the sinusoids. And those are filled with blood. So in the liver, those large fenestrations allow proteins that are synthesized by the liver, like albumins, to enter the blood, and then they drain out of the tissue of the liver into the hepatic veins, and then into the inferior vena cava, and then back up to the heart. All right, then finally, the last type of blood vessels are called veins. Veins return blood to the heart, and they're sometimes referred to as the capacitance vessels. They're called the capacitance vessels because they have the capacity to accommodate large volumes of blood. And the reason they can do that is because they have fairly thin walls. Their walls are so thin, in fact, that it's hard to see veins in a cadaver, especially if the blood has been drained out of all the blood vessels. Because their walls are so thin, they collapse, and it makes them hard to see. So your veins, for example, your veins in your legs can actually accommodate larger volumes of blood that are pulled down into the lower part of your body by gravity. And that's why there's special mechanisms to help return the blood back to the heart. One of those mechanisms is called the skeletal muscle pump, where the muscles squeeze the blood in the veins, and the blood is squeezed so it goes back up to the heart. So at rest, about 64% of our blood volume is found in the veins. So a lot more blood in the veins at any one time than in the arteries. The main reason for that is once blood has gone through the capillaries have such small diameters, they have a lot of resistance to flow. And so blood loses most of its pressure as it goes through the capillaries. So the blood in the veins is not under very high pressure. And it's under such low pressure that it makes it harder for that blood to get back to flow back to the heart. Now, the very smallest of the veins that receive blood from the capillaries are called postcapillary veins. And those are surrounded by pericytes, which are little cells sort of like smooth muscle fibers. And those pericytes can then control the flow of blood through the venules. Postcapillary venules have a tunica intima with few fibroblasts and no smooth muscle surrounding it. And so their thin walls allow for the exchange of fluids with surrounding tissues. So they're very leaky. A lot of the fluid from the blood leaks out of the smaller venules. That's one of the reasons why we need a lymphatic system to return that fluid back to our circulatory system. And then there are larger venules called muscular venules. They receive blood from the postcapillary venules. These are up to 1 millimeter in diameter, so they're really small. And their tunica media has only 1 to 2 layers of smooth muscle. And they have a very thin tunica externa. So these are really hard to see, they're so tiny. And then the next one are the medium veins. They're up to about 10 times larger than the smaller ones. Most of the named veins are medium veins. So like the renal veins, the iliac veins, anyway, most of the smaller veins are medium veins. The tunica media of medium veins has a few discontinuous smooth muscle fibers, but is thinner than medium arteries. And most of these have infoldings of the tunica interna that actually form internal valves. This is an example of an internal valve that allows blood to flow towards the heart, but if gravity pulls the blood back down, it causes those valves to close, so the blood can't be pulled clear down into your feet. And then finally, the largest of the veins are called venous sinuses. These are just very large, broad, blood-filled spaces. A good example of a venous sinus is the coronary sinus, which is on the posterior side of the heart. That receives blood from the great cardiac and middle cardiac vein, and then returns that blood to the right atrium of the heart. Another example of sinuses is there's dural sinuses surrounding your brain that receive blood that's returned from the brain, and and then blood from those dural sinuses eventually goes down through the internal jugular vein. The sinuses don't have smooth muscle in their walls, so their diameter can't be changed. Okay, well, we're out of time, so this is a good place for us to stop here. So we'll stop, and then our next main topic is going to be blood pressure.